Hello, doctors. This is Dr. Brody here once again, and we are about to get into the game to, learn a little bit about approach to infertility. And this is going to, focus on the MCQE1. So please make sure that if you are joining us on Facebook or YouTube, you get your friends to join us, and then we'll get it going. At the same time, what I will do is that I want to know, where are you joining me from? Where are you joining me from? Where are you joining me from? So I have Dr. Yvette, who is watching on YouTube, who says, hello, Dr. Brony. And I'm also saying, hello, Dr. Yvette. At the same time, you know what? What I want to do is, I don't want to stay on this stream alone. So if you want to join me live, you can click on the link I'm sending in the comment section to join me, okay? But make sure that your camera is on. Okay, so Dr. Yvette is joining me from Saskatoon. I am in Saskatchewan as well, but I'm about 4 hours away from Saskatoon, okay? And I have Dr. Jackie as well joining me from Mississauga. At the same time, I want you to know, I think I've told my people in the program that I will be in Ontario this week. So if anyone wants us to meet, I'll be in the Hamilton area. We'll be attending a conference there on addiction medicine. So if you want us to meet, just let me know. My phone number is what is rolling down there in the comments down there, +1 306 891 5649. +1 306 891 5649. +1 306 891 5649. Just send me a WhatsApp. We can arrange and meet, at the conference site and, just network. Oh, I also have someone who is joining us from South Africa. He says Facebook user, South Africa. So doctors, the numbers are increasing. Please make sure you send the link to all your friends who are also preparing for the MCCQE1, okay, so that they can join and then we can all study together. Just send the link to your friends, send the link to your friends, send the link to your friends, and let's all get going. So I'm going to share my screen, and then we're going to start the game. I'm going to send my screen, and then we're going to start the game. So today, we're going to deal with approach to infertility. Approach to infertility. Very, very important topic for the MCCQE1 exam. And we're going to dive right into it. Okay. Someone is also joining us, Facebook user Sudbury. So look, doctors, make sure you've invited all your friends. Let them join us right now, and let's get a ball rolling. At the same time, I'm putting the link in the comment section. If you want to join me live as well, but your camera needs to be on so that you can be reading, the questions as well. That will also be awesome. Okay. So this is how the link is in the comment section on Facebook and on YouTube. You can use that to join, and then we get the ball rolling. And then we also have Facebook user as well, says he's joining us from Toronto. Okay, so let's get into the game because it's Remembrance Weekend. I don't want to waste anyone's time. I know we need to spend time with family. So, but at the same time, we need to also prepare for our exam, right? So let's get going. So, approach to infertility. Approach to infertility. At the same time, please make sure you go to our YouTube channel, click on the subscribe button, okay, and click on the double notification so that if any message comes out there, you are alerted and you can watch it right away. So this class is currently also being run live on Facebook and on YouTube. So please make sure you are joining us. We're doing approach to infertility. Okay. So I want to welcome all of you, and we're going to get into it. Why should we focus on infertility? Because number one, it's an MCC objective. And someone may say, Dr. Brony, how sure are you that it's an MCC objective? I always tell you that, look, doctors, I'm the crusader for MCC objectives, okay? I don't like to mess around with MC objectives, and I want to make sure that we focus on it. So someone may say, how sure are you that this is an important topic? First, I'll share my screen, and then we'll go to the MC objectives, and then we'll see what the MCC objective itself says. Okay, so let's go to infertility. Okay, good. So there we go. There we go. There we go. This is an MCC objective, infertility, and there we go. Okay, so it talks about the rationale. We're going to go through that. It talks about the causal conditions, it talks about the key objectives, the enabling objectives, and then you are done. So why am I focusing on it? It's in the MCC objective. It's in the MCC objective. Simple as that. It's in MCC objective. Okay, so I will unshare my screen and then I will load my presentation again. Okay, good. So, doctors, we are dealing with it because it's in objectives. And if it's in objectives, make sure that Dr. Boni will cover it. So, infertility is a common condition that is defined as the inability of a couple to conceive after 1 year of intercourse without contraception. Okay, so that's the definition. 1 year of intercourse without contraception. Both partners must be investigated. So, infertility is not a problem for only the female partner. The male partner must also be investigated. Now, what are the causal conditions? The list is not exhaustive, but consider to master by the end of the objective review these causal conditions. Ovulatory dysfunction, that is hypogonadotrophic hypogonadism. That's one of them. Polycystic ovarian syndrome. That's another thing you need to master if you want to ace this particular exam. Okay. And then tubal and peritoneal abnormalities like pelvic inflammatory disease. So if you are listing your topics that you need to master, make sure that you've mastered PCOS. Okay. If you've not mastered PCOS, you've not mastered infertility. If you've not mastered pelvic inflammatory disease, you've not mastered infertility. If you've not mastered uterine fibroids, you've not mastered infertility. Okay. Oh, we have someone joining us from Kenya. Hi, Dr. Bruni, joining from Nairobi, Kenya. Keep doing the good work. Awesome. So, we are getting people join us from all over the world. So, doctors, that's why it's very important, right, to get friends and family to join. Others are joining us from Vancouver. Okay, good. So, I'll continue. It says that, so hypogonadotrophic hypogonadism, polycystic ovarian syndrome, please write these down because you need to master these. Okay. Then tubal peritoneal abnormalities like pelvic inflammatory disease, and then uterine and cervical factors like uterine fibroids. Okay. So for those in MedCognito already, you realize that if you go to especially your gynecology portal, these have been dealt with. Infertility has also been dealt with, and these topics have also been dealt with. South Africa is also joining us in the building. Then if you go to male concerns, you have hypogonadotrophic hypogonadism, okay? And then viral orchitis as well. And then post-testicular dysfunction like abnormal sperm transport. So doctors, please, if you've not mastered mumps, if you've not mastered hypogonadotrophic hypogonadism, if you've not mastered uterine fibroids, if you've not mastered pelvic inflammatory disease, polycystic ovarian syndrome, hypogonadotrophic hypogonadism, please, you've not mastered this topic yet. Now, what are the key objectives? Given a couple with infertility, the candidates will diagnose the cause and complications and will explain therapeutic options. So, when you are learning about infertility as well, you must also learn, what are the options for management? IVF, IV, like all the various options. If a patient has polycystic ovarian syndrome, what should be done? If a patient has tried several times to conceive with a partner and it's not working, what are the other options which can be used, right? What about IVF? Who qualifies for it? What are the indications? All those, what are the complications? These are the things that you need to master. These are the things you need to master. Wow. Someone is joining us from Tunisia. Powerful. Tunisia in the building. Okay. So given a couple with infertility, and that's Dr. Lamia. That's powerful. I'm very glad. The candidate will diagnose the cause and complications and will explain the therapeutic options. Okay, therapeutic options. Now, I go on. So the enabling objectives. Given a couple with infertility, the candidate will list and interpret critical clinical findings, including those derived from an appropriate history and physical exam of both partners. So you need to know, if you are taking a history of a patient with infertility, how are you going to go about it? And this also goes for our NACOSCI candidates, right? Because the NACOSCI exam also follows the same MCCQE1 objectives. So if you want topics that you need to master for the NACOSCI, make sure that you come to the MCQ1 objective and you learn all the objectives there. So one of them is that you need to know how to take the history and how to perform physical exam of both the patient and the partner, okay? And list and interpret critical investigations, including semen analysis. So if you are presented with semen analysis in your exam, how are you going to interpret it? What are the tests you can do to confirm ovulation? Okay. Other laboratory tests like prolactin levels, thyroid stimulating hormone levels, and then construct an effective initial management plan, including counseling the couple regarding preconceptual use of folic acid, which people need 0.4 milligrams of folic acid, which people need 5 milligrams of folic acid, which people are, what dose of folic acid will you give to a patient who has used methotrexate? These are the things that you want to focus on, or who has had a previous history of neural tube defect. Maybe the patient delivered a baby with spinal bifida occulta, prosencephaly, anencephaly. What dose of folic acid will you give? These are the things you want to focus on. And then counseling and educating the couple regarding diagnostic and therapeutic options. And then determining whether either the patient requires specialized care. So under what circumstance will I refer someone to a specialist? And then recommending changes to workplace environment if needed. Okay, so as a doctor, you must know if your patient needs some changes in the workplace environment. You've got to know. And then providing counseling regarding psychosocial stresses if indicated. Doctors, I've not had any like or share on the YouTube channel and the Facebook, so I want us to pause. Go to our YouTube channel right now. It's running live. Please give us a thumbs up there, so that we know that you are following on our YouTube. And please make sure you subscribe and you subscribing to the YouTube. Make sure that you're subscribing to the YouTube so that we can get the best out of it. Make sure that you are subscribing to the YouTube so you can get the best out of MedCognito and everything we're putting out there on YouTube. Okay, so if you want to find out our YouTube channel, just go to medcognito.com. Okay, medcognito.com, and everything will be there for you. Okay, currently we are sitting at 1,290 subscribers. I want that by the end of this live stream we should be at 1,350 subscribers. So please go to our YouTube channel right now, click on the subscribe button, like it, so that we can get the ball rolling. Okay, good. So today we're going to focus on polycystic ovarian syndrome. We're going to do a laser focus approach to polycystic ovarian syndrome so we can get the best out of it. Okay, Okay, polycystic ovarian syndrome. Let's get into it right away. And usually you realize that at MedCognito, we'll start with questions and then we go into the topic. So I'm starting with the first question. Please just type in your answers. If it is A, if it is B, if it is C, if it is D, if it is E, just let me know. So you have a 16-year-old girl who presents with concerns about her menstrual cycle. She reports having only 4 periods in the last year. She also has mild hirsutism and moderate acne. What's the best next step in management? A, immediate start on combined oral contraceptives. B, further evaluation for polycystic ovarian syndrome. C, reassurance and follow-up in 1 year or in a year. D, begin metformin therapy. Doctors, please give me your answers. Give me your answers right away. A, B, C, or D? A, B, C, or D? A, B, C, or D? I'm waiting. I've seen some answers coming through. I've seen a few answers coming through. I want as many people as possible to take their time to answer this question before I move on. And what is your rationale? What is your rationale? What is your rationale for doing that? Okay. What is your rationale for doing that? That's the next thing you want to focus on. Okay. So it looks like a lot of people went for B. Further evaluation for polycystic ovarian syndrome. And that is the correct answer, by the way. Further evaluation for polycystic ovarian syndrome. That's the correct answer. And why? Why are we doing that? So, Dr. Kalala, please, you want to check it well. Okay, Dr. Nkule Kalala, you went for C. That is reassurance and follow-up in a year. So the answer is, if you have a patient with menstrual irregularity, hirsutism, like hair on the face, acne, menstrual irregularity with hirsutism and acne, further evaluation for polycystic ovarian syndrome is warranted, right? While oral contraceptives and metformin are treatment options, they should be started after confirming the diagnosis. So you want to confirm the diagnosis first before you even do any other thing for this particular patient. So you want to do further evaluation for polycystic ovarian syndrome. Okay, next question. Which of the following is not a criterion used to diagnose PCOS in adolescents? Which of the following is not a criterion for diagnosing PCOS in adolescents? A, persistent menstrual irregularity for over 1 to 2 years. B, biochemical evidence of hyperandrogenism. C, presence of multiple ovarian cysts on ultrasound. And D, elevated prolactin levels. Which of the following is not a criterion used to diagnose polycystic ovarian syndrome in adolescents? Doctors, I'm waiting for your answer. I'm waiting for your answer right away. I'm waiting for your answer. So the following is not a criterion. So the following is not a criterion. A, B, C, or D. And I see a lot of people now going for D. Dr. Aisha went for C, presence of multiple ovaries on ultrasound. Well, Dr. Aisha, you may want to check your answer as well, because for this patient, elevated prolactin levels is not a criterion for diagnosed polycystic ovarian syndrome. What do I mean by that? Elevated prolactin levels are associated with hyperprolactinemia, not polycystic ovarian syndrome. The other options are part of the diagnosis of polycystic ovarian syndrome. So, how do we diagnose polycystic ovarian syndrome? Biochemical evidence of hyperandrogenism, that's number one. Number two, presence of multiple ovarian cysts on ultrasound. And number three, persistent menstrual irregularity for over 1 to 2 years. These are the diagnostic criteria for polycystic ovarian syndrome. Let's go to the next question. You have a 15-year-old girl who presents with concerns of severe acne and infrequent menstrual periods. On exam, she has moderate hirsutism. Her BMI is within normal range. Which of the following findings would most strongly support a diagnosis of PCOS? Which of the following findings would most strongly support a diagnosis of PCOS? A. Acanthosis nigricans. B. Elevated serum testosterone levels. C. Decreased TSH levels. D. Elevated FSH levels. Doctors, what is your answer? I see that this particular question, there looks like, confusion in a camp. I see people choosing A. Facebook user is choosing A. I see Dr. Jean also choosing D. I see Facebook user, different doctor choosing B. I see Dr. Aisha, Dr. Alex choosing B, right? So various answers. Our doctor from Tunisia also choosing B. So what is it? 15-year-old girl presents with concerns of severe acne and infrequent menstrual periods. On exam, she has moderate hirsutism. BMI is within the normal range. Which of the following findings would most strongly support a diagnosis of PCOS? And what is the correct answer? Drum roll. The correct answer is elevated serum testosterone levels. Elevated serum testosterone levels. That is B. So if you chose D or A, no, please review your answer. And why is B correct? Elevated serum testosterone is a key biochemical indicator for hyperandrogenism, okay, which is central to the diagnosis of polycystic ovarian syndrome. The other findings are less specific. So if you are looking for one of the key biochemical indicators of elevated androgen, levels, that is hyperandrogenism, think about elevated serum testosterone levels. Okay. Taking you to the next question. Which of the following best describes the relationship between insulin resistance and polycystic ovarian syndrome? Insulin resistance and polycystic ovarian syndrome. Because, we know that patients with polycystic ovarian syndrome have a high risk of developing insulin resistance and even going on to develop diabetes, right? So, which of the following best describes the relationship between insulin resistance and polycystic ovarian syndrome? A. Insulin resistance is uncommon in polycystic ovarian syndrome. B. Insulin resistance is a cause of PCOS in lean individuals only. C. Insulin resistance plays a significant role in the pathophysiology of PCOS regardless of the BMI. And D, insulin resistance in PCOS is due to hyperthyroidism. And I see a lot of doctors going for C, right? A lot of doctors are going for C. So it looks like we are picking it up. And for me, one exam taking trick, like even B, how do I eliminate B? Insulin resistance is a cause of PCOS in lean individuals only. Doctors, what is one word there which makes even B, beyond our knowledge of PCOS, one of the least desirable answers? There's one word in B which makes it one of the least desirable answers. Why? What? Beautiful. Dr. Jackie got it right. Dr. Jackie got it right. Only. That word, only. In medicine, you want to be very careful about only. You want to be very careful about never, right? You want to be very careful about those things. Dr. Sergio Dansu is saying only as well. So that's powerful. Good. Looks like class participation is all-time high. Very, very class on steroids today. So I like that. So the correct answer is C. Insulin resistance plays a significant role in the pathophysiology of PCOS, regardless of BMI. And you realize that even in lean patients, they can still have insulin resistance, right? Okay, good. Now, you have a 25-year-old woman with epilepsy, is being treated with valproate. She develops irregular menses and hirsutism. What is the most likely diagnosis? Sodium valproate for seizures and epilepsy. What can it lead to? Can it lead to Cushing syndrome? Can it lead to hypothyroidism? Can it lead to polycystic ovarian syndrome, or can it lead to hyperprolactinemia? Which of these? So what's the relation between seizures, valproate, and one of these conditions? So a lot of doctors are going for C. And for me, that's beautiful. Looks like, people are really, really, really paying attention. So valproate, which we give to patients with seizures, has been associated with increased risk of developing polycystic ovarian syndrome, which includes symptoms like irregular menses and hirsutism. So sodium valproate, we know that we use it to manage patients with seizure. However, it can also predispose or increase the risk of developing PCOS. So that's something we want to learn. And I want to, because of this, go into a deep dive. Okay, go into a deep dive so that you can learn something. So high risk groups of females who have increased risk of developing PCOS. Number one, patients with oligo-ovulatory infertility. Okay, very light bleeding, irregular menses. Number two, obesity and insulin resistance. That's also very critical. Number three, type 1, type 2, or gestational diabetes. Number four, a history of premature adrenarche. Very important. Number five, first degree relatives with PCOS, polycystic ovarian syndrome. These are high group individuals, who have a high risk of developing PCOS. Number six, certain racial and ethnic groups. So which of the racial and ethnic groups have an increased risk of developing PCOS? Mexican Americans, okay? Indigenous Australians. So doctors, you're going for an MCQ exam next year, right? So these are, specific stuff that you need to know if you're preparing for the exam. And then use of anti-seizure medications we learned today. For example, sodium valproate, okay, valproic acid. So even if you are asleep and, I ask you, the following groups of people have increased risk of developing polycystic ovarian syndrome. Except then I list some of these and I put something, out of the blue there. You should be able to pick it up, right? Good. Let's continue. Another question. Doctors, please, I have a question before we move on. Are you okay with the question and answer approach we are using? Are you okay with the question and answer approach we are using? If you're okay with it, just type yes, 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 yes. Let me know. If you are okay with the question and answer approach that we use, please type in yes, 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 and let me know. Okay? Please. If you also want us to change the strategy as well, let me know. I know that this strategy works for a lot of people because then we get to solve so many questions about the topic. And then we are looking at the topic from all the various angles, right? Exactly. Okay, good. So Dr. Krenzel says yes. Dr. Genevieve Polo says yes. Dr. Isaac says yes. Okay, beautiful. So we'll continue then. Okay. So next question says, a study finds that females with a history of polycystic ovarian syndrome have a 30% prevalence of the disorder compared to 10% of the general population. What does this suggest about the etiology of PCOS? A, PCOS is purely environmental. B, PCOS is simple genetic trait. C, PCOS is a complex genetic trait with both genetic and environmental influences. D, PCOS is not heritable. What's your answer? What's your answer, doctors? What's your answer? And don't mind, you can share the link with your friends on Facebook and on YouTube. You can share to your various Facebook and YouTube, links and all those things. I don't have a problem about that because we are here to make sure that we help everybody, right? So send this link to your various WhatsApp groups, send it to the various YouTube groups, Facebook groups, so you can get as many people as possible joining us to study with us. All right? Okay, good. So what is our answer here? Our answer here will be C. Polycystic ovarian syndrome is a complex genetic trait with both genetic and environmental influences. Okay, yeah. The higher prevalence of polycystic ovarian syndrome in females, the family history indicates that PCOS is a complex genetic trait. While genetics play a significant role, environmental factors also contribute to the development of the disorder. And one of the environmental factors we've learned today is the use of sodium valproate. Okay, good. Another question. You have a 16-year-old girl who presents with severe acne, irregular periods, and increased facial hair growth. She has a BMI of 30 and dark patches of skin on the neck. Which of the following is the most appropriate next step in evaluation of her condition? A, blood glucose testing. B, serum testosterone level. C, pelvic ultrasound. D, oral contraceptive therapy. And E, fasting lipid profile. Doctors, please make sure you like our YouTube channel. Make sure you like our YouTube channel. Make sure you subscribe as well. Okay? Make sure you subscribe. So we're still sitting at 1,292. Doctors, please help us to grow our YouTube channel. Go there, click on the subscribe button right now on YouTube. Click on the subscribe button right now. While you do that, let's solve the question. 16-year-old girl presents with severe acne, irregular periods, increased facial hair growth. She has a BMI of 30, dark patches of skin around on her neck. Okay. Which of the following is the most appropriate next step in the evaluation of the condition? A, blood glucose testing. B, serum testosterone level. C, pelvic ultrasound. D, oral contraceptive therapy. E, fasting lipid profile. See a lot of people going for B. Some are also going for C. What's the correct answer? The correct answer is B. B. The first step in evaluating suspected PCOS is to measure the serum testosterone to check for hyperandrogenism. Okay, hyperandrogenism. The one who wrote A, Facebook user who wrote A, remember that it's checking the glucose level is important, but that's not the first thing. Because the issue of insulin resistance and diabetes is a secondary thing. It's a complication of the PCOS, right? But then you want to check your serum testosterone level, to measure for hyperandrogenism. It's a hallmark of the condition. Blood glucose testing and fasting lipid profiles are important for evaluating associated metabolic risk. It's like the glucose we talked about. But confirming hyperandrogenism is critical for diagnosis, because pelvic ultrasound can be useful, but it's not required for diagnosis. Okay. Good. Next question. Whoa, we have so many people joining us today. This is awesome. Doctors, please make sure you subscribe to the YouTube channel. Next question. A 15-year-old girl is diagnosed with PCOS. Her laboratory results show slightly elevated testosterone and normal 17-hydroxyprogesterone levels. Which additional test is most important to evaluate her risk of future complications? So look at this. Risk of future complications. A, oral glucose tolerance test. B, complete blood count. C, serum cortisol. D, pelvic ultrasound. E, bone mineral density. So that means for you to answer this question, you have to know the complications of PCOS, right? And when you know the complications of PCOS, so Dr. Ronnie went for A, oral glucose tolerance test. Dr. Togbo went for A, oral glucose tolerance test. Some are going for D, pelvic ultrasound. But I have a question. Which complication of PCOS are you going to monitor with serum with pelvic ultrasound, right? So the answer is A, oral glucose tolerance test. Why? Because PCOS is a predisposing factor for insulin resistance and diabetes. Okay, so an oral glucose tolerance test is important due to evaluate the risk of type 2 diabetes, okay, which is higher in patients with PCOS, okay, due to the insulin resistance. While other tests may be relevant depending on the symptoms, OGTT directly assesses a major long-term risk associated with PCOS. So that's why we went for A and we didn't go for D. D, I don't know exactly what you are going to the complication you are going to assess for. I'm very happy. Today we are dealing with a lot of questions, and then we go in. So next question. In evaluating an adolescent with suspected PCOS, which of the following laboratory findings would most strongly support a diagnosis of PCOS? A. Elevated fasting blood glucose. B. Elevated luteinizing hormone with normal follicle stimulating hormone. C. Elevated serum prolactin. D. Low TSH. And E. Low serum estrogen levels. What answer will you go for? In evaluating adolescents with suspected PCOS, which of the following findings will most strongly support diagnosis of PCOS? So some are going for A. Dr. Ronnie went for B. Dr. Jackie went for B. Dr. Krenzel went for B as well. And the answer is B. So the B gang, you got it right. B gang, you got it right. Participation is very good in the class. So an elevated LH-FSH ratio is commonly found in PCOS and supports a diagnosis, especially in the presence of hyperandrogenism and menstrual irregularity. So if the LH is way higher than the FSH, and the ratio is usually more than 2:1 of LH to FSH, you're good to go. Okay. So doctors, how was the question session, please? How was the question session? But we're going to do a deep dive into some concepts on PCOS. How was the question session? I need your feedback. Sure. So Dr. Krenzel says, awesome questions. Dr. Krenzel says, awesome questions. Dr. Aisha says, B. Okay. Dr. Lamia says, good. Oh, okay. Facebook user says, beautiful. Like the way I say my stuff, right? Okay, good. Now, let's get into it. Let's do a deep dive into PCOS. So, polycystic ovarian syndrome is the most common cause of infertility in women. So, someone also says, this method challenges is a challenge and it helps us to learn a lot. Beautiful. I like that. So why are we learning about polycystic ovarian syndrome? Polycystic ovarian is the most common cause of infertility in women, often beginning during adolescence. Okay, often beginning during adolescence. Someone also says it's a summary of PCOS. Beautiful. It's characterized by a mix of symptoms, primarily issues with ovulation and an excess of male hormones. Okay, so excessive male hormones, concerns with ovulation, you are good to go. What are the key features of PCOS? Because we dealt with a lot of questions which went with this. Okay. Dr. David Motumbo says, amazing, beautiful. So, what are the key features of PCOS? Excess hair growth. So much hair on the face, and you realize that maybe the patient has been plucking it or maybe shaving it. Severe acne or scalp hair thinning. So the hair can become thin. Okay. And there can be menstrual irregularity where the patient may have fewer or no periods. And there can be polycystic ovaries. Ovaries have many small fluid-filled sacs. That's a cyst. And then there can be obesity and insulin resistance where many women with PCOS are overweight. Okay. Many women with PCOS are overweight. And may have insulin resistance. So these are the things: menstrual irregularity, hair thinning, hyperandrogenism, excessive hair growth, severe acne, fewer or no periods, When you do an ultrasound, you see fluid-filled sacs on the ovary. What are the long-term complications of PCOS? It can lead to metabolic syndrome, where they can, patients can have high blood pressure, high blood sugar, excessive body fat around the waist, abnormal cholesterol levels that increase the risk of heart disease and diabetes. Okay. One other complication can be metabolic type 2 diabetes, which can be as a result of the metabolic syndrome that the patient has, right? And insulin resistance is common in PCOS. It leads to increased risk of developing type 2 diabetes. Sleep apnea as well is also another very, very important complication of PCOS you have to know, especially because of the increased weight gain, right? And then possible cardiovascular disease. And then there's a risk of endometrial cancer. Why? Because of the irregular periods that can lead to a buildup of the uterine lining, increasing the risk of endometrial cancer, right? Endometrial cancer. Now, how are you going to nail a diagnosis of PCOS in the MCQ1 exam? How are you going to nail it? You want to look for evidence of hyperandrogenism. So you want to look for that patient who is said to have a lot of hair on their face, a lot of acne, they may have some hair loss, pattern alopecia, and they may have persistently elevated serum testosterone levels. This is how to nail it. Because, in MedCognito, what we try to do is not to teach you long, boring stuff. No, rather to go bam, bam, bam. Focus on what you need, and then you go home. Go ace the exam and go home. That's all we're looking for. So you're looking for all these hirsutism, persistent acne, pattern alopecia, persistently elevated serum testosterone, plus a menstrual pattern which is abnormal. It's either irregular, oligomenorrhea, amenorrhea. They may have even some patients who may at times have excessive bleeding. And this persists for at least 1 to 2 years. At least 1 to 2 years. And they must have at least two of the three. Okay, so hyperandrogenism, ovulatory dysfunction, and then when you do an ultrasound, you can see a polycystic ovary. So if they have 2 of these, your diagnosis is spot on. Boom. Now, the associated metabolic features of polycystic ovarian syndrome can be obesity, insulin resistance, leading to acanthosis nigricans, where you see, these dark patches in the neck and in the armpits and all the creases, okay, and metabolic syndrome and type 2 diabetes. So these are the things you want to look out for. How will the patient present clinically? They'll present with hirsutism. They'll present with acne. They'll tell you that, look, doctor, I have irregular menses. Now, after you've seen all this, after you've noted the complications, so let's go. Doctors, can you please type, what's your diagnostic criteria for PCOS? Please type it in the comment section. Your diagnostic criteria for PCOS, please type it. Please type your answers. Diagnostic criteria for PCOS. I want to see your answers right now. Diagnostic criteria for PCOS. Diagnostic criteria for PCOS, please. Diagnostic criteria for PCOS, please. Just type it before we go to the management of PCOS. Abnormally high testosterone, okay, sure. But we said FSH to LH ratio. We talked about polycystic ovarian ovaries on ultrasound. We talked about, the physical exam features, the acne, the hirsutism, the oligomenorrhea, the amenorrhea, that kind of thing. Okay. So what are the goals of treatment of PCOS? Number 1, you want to reduce androgen symptoms. Managing excessive hair growth and acne. That's the first thing. Those are the goals, right? Goals. Number 2, you want to improve metabolic health. Where you address issues like obesity, like insulin resistance, to prevent type 2 diabetes and heart disease. Number 3, You want to prevent endometrial issues. Why? Because we learned that patients with polycystic ovarian syndrome stand a higher risk of developing endometrial cancer. Number 4, you want to deal with the issue of contraception, where you can, provide birth control to prevent unwanted pregnancy. And then number 5, fertility treatment. So you can, some patients with polycystic ovarian syndrome, as we said, is the number 1 cause of infertility in females, right? So let's go. What are the steps in the management? The first step is diet and exercise, right? Diet and exercise. Diet and exercise. Diet and exercise. That's the first step. That's the first step, diet and exercise. So the first step for overweight women is weight loss, which can help to restore regular periods and reduce the metabolic risks. So diet, they should watch their diet, they should exercise. 2 things. Okay. The next one is oral contraceptives. Oral contraceptives, these are commonly used to manage hormone levels and to reduce male hormone effects and to regulate menstrual cycles. Okay. Because women over 40 who are obese should be careful when using pills. Why? Because of the risk of developing deep vein thrombosis, DVT. And if you're not also careful, they can even go on to develop pulmonary embolism. So when you're using oral contraceptives, be very careful. If you are giving someone who has, increased age, you want to be very careful. Okay. And then, what about patients who are not trying to give birth or who are not trying to get pregnant? Managing menstrual cycles and preventing uterine issues. Birth control pills are recommended. Okay. If the patient is not planning on getting pregnant, birth control pills are recommended. If birth control pills are not suitable, other hormone therapies like progestin-only pills or hormone-releasing IUD can be used. I'm talking about patients who are not trying to get pregnant. Okay. Now, what about excessive hair growth? You can start with birth control pills, and then if there's no improvement, you can add an anti-androgen medication like spironolactone. And if the birth control pills are not an option, spironolactone can be used alone. But contraception is needed to prevent pregnancy. So if the patient does not want to get pregnant, you can use spironolactone, especially if they have excessive hair growth. Okay. What about patients who are trying to get pregnant? So you see, doctors, you want to deal with this whole issue of polycystic ovarian syndrome in 2 ways. Patients who are trying to get pregnant, patients who are not trying to get pregnant. Okay. So those who are trying to get pregnant, you want to make sure that you talk about weight loss. You want to deal with the issue of weight loss. Okay. Because if they are not losing the weight, that can affect, all that you try to put in so far as your fertility treatments are concerned. And ovulation induction, letrozole is recommended as a first line now. Letrozole. I saw that someone had put in clomiphene citrate. The recent literature, and that is why, doctors, you want to use the correct source. Letrozole is recommended as the first line treatment for helping women with PCOS to ovulate. Letrozole. Let me say that again. Letrozole. I'll say it 5 times. Letrozole number 1, letrozole number 2, letrozole number 3, letrozole number 4, letrozole. I'm saying with a big smile because that is what the latest evidence talks about, doctors. Okay, so now that we've talked about all those things, let's talk about some more questions. So you have a 28-year-old with BMI of 32 kilogram per meter squared, presents with irregular periods and unwanted facial hair. She has been diagnosed with PCOS. Which of the following is the first line treatment for her condition? A, spironolactone. B, metformin. C, oral contraceptive pills. D, letrozole. BMI is high, irregular periods, unwanted facial hair, what's your next best step? I see a lot of people going for C, 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 C. I see a lot of people going for C. And the correct answer is C. Correct answer is C. Correct answer is C. Doctors, I'm so happy. People are catching up to it. I'm very, very happy. So, oral contraceptives are the first line treatment for managing hyperandrogenism, that is excessive hair growth, and menstrual irregularities in women with PCOS. They help to regulate the menstrual cycle and to reduce male hormone levels. Okay? And to reduce male hormone levels. Next question. So that you go for hormone contraceptive pills. A 26-year-old woman with PCOS has been on oral contraceptives for 6 months to manage her hirsutism, but her symptoms have not improved. What is the next step in her management? A, increase the dose of the contraceptives. B, spironolactone. C, switch to metformin. D, start gonadotropin therapy. Doctors, I'm very happy now. You're able to decipher this thing. Oh my goodness, water is good. I'm enjoying the water like crazy. Okay, so now I think doctors are able to decipher this thing. And I see a lot of people are going for B, 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 B. And the answer is B. Because we said that when we were doing the deep dive into the management, we said that if you try the oral contraceptives and it's not helping, you can do spironolactone. And if the patient has a contraindication for oral contraceptives, then you want to go with spironolactone. Okay, so if the response to oral contraceptives alone is inadequate for controlling hirsutism, adding an anti-androgen like spironolactone is recommended. Beautiful. Next question. Yeah. A 35-year-old woman with PCOS and a history of venous thromboembolism is seeking contraception. Ooh, that's very critical for us to know, right? Which of the following is the most appropriate option for her? A, combined oral contraceptive pills. B, progestin only pill. C, spironolactone. D, metformin. This patient has a history of venous thromboembolism. Now, this patient is seeking contraception. Which of the following is the most appropriate option for her? A, combined oral contraceptives. B, progestin only pill. C, spironolactone. D, metformin. And the answer is progestin only pill. Progestin only pill. Remember, we learned that. Because if you give her oral contraceptive pills, oh my goodness, you are increasing the risk of developing another venous thromboembolism. So that's why you're going with progestin only pill. Okay, so you know what? We are about to phase out CDM by November 20th. That's when the last person will write the MCCQE1. But I just wanted to throw in a CDM question. Let's do one CDM question. So, 29-year-old woman with PCOS trying to conceive. She's tried lifestyle modifications, including diet, exercise, resulting in a 10% reduction in body weight. However, she still has irregular menstrual cycles. Which of the following treatment options would be the best next steps? Choose two. A, metformin. B, letrozole. C, clomiphene citrates. D, spironolactone. D, laparoscopic ovarian drilling. E, progestin only pill. F, progestin only pill. G, in vitro fertilization. H, bariatric surgery. I, gonadotropin therapy. J, acupuncture. K, cyclic progesterone therapy. L, low dose aspirin. M, myo-inositol. N, thiazolidone diones. O, dietary supplements. P, continuous positive airway pressure, CPAP. Q, combined estrogen progestin oral contraceptives. R, herbal treatments. And S, hormone replacement therapy. Look, they are phasing out CDM in 10 days, no more CDM. But I was like, you know what? For those who are going for the exam last minute, let me throw in something. Let me throw in a CDM and let's see. So I see a lot of people going with A and B. Letrozole. Someone says, are we going till Z? No, we're not going till Z. So, in fact, let me say this. A is also correct, okay? A is also correct. So if you went for A and B, you are correct. And if you go for B and C as well, you are correct. In fact, what is even happening was that C is being phased out. Clomiphene is being phased out in some jurisdictions. So the correct answer is A, B, or C, okay? So A is also correct. Metformin is also correct. Metformin is also correct, okay? All right. So, doctors, I'm just letting you know, really enjoy the time with you today. Remember that practice makes perfect. Practice makes perfect, and that is why we're also making sure that as much as possible you get exam preparatory tips for your MCQE1. In fact, that's what we are doing for all our courses now. Okay, so on November, I'm just checking the date here. On November 18th at 6 p.m. EST sharp, we're going to do. Oh, someone is asking about what about oral contraceptives? Remember that the patient wants to get pregnant. The patient wants to get pregnant. So why are you giving oral contraceptives, right? Blessed. The patient wants to get pregnant. So if you give oral contraceptives, you are just wasting the patient's time. Okay? Okay, good. So on November 18th, we're doing a 3-hour mock. A 3-hour mock exam. And it's only 69 CAD. $69 for those who are not MedCognito students. But for MedCognito students, it's $24. So those who like to take the mock, I'm putting the link in the comment section where we cover all subjects, and you have a live invigilator who is monitoring you, putting you under exam condition, like those who are doing the remote proctoring, right? And that is one thing I've seen has been helping a lot of our students, where they go through mock exam upon mock exam upon mock exam. And that is why you have people who have failed 3 times. They come to MedCognito on their last attempt. They have to wait for a year. Boom, they pass it. Why? Because we do so many mock exams. You also have even a mock exam in your portal itself. So on the 18th, we have our mock exam coming on. And it's going to be MCQs only, because that will be 2 days to when they stop the CDM, and we don't want to waste your time, because a lot of people are preparing now. They are preparing for the exam for next year. Okay. And tonight, we have a class again. Tonight, we have a 3-hour class on ethics. Ethics. I love ethics because, you know what? At times the concepts are a bit confusing, and then you get candidates to get in there. So if you are new to this whole MedCognito game, I just want you to note something. If you come to our portal, and I'm going to show the screen, if you want to prepare for this ethics class, okay, all you need to do is to go to the screen, go to MedCognito, okay, and then where is it? This. Okay, so if you want to be part of the game, just go to here, go to www.medcognito.com, click on profile, okay, and then click on membership, and then you will get access to the whole MedCognito program. So for example, tonight, ethics, okay, before you come to the class, make sure that you go to this portal, make sure you click on this portal, and then in fact, you can even watch some high yield review topics on ethics. And then you can review the class on ethics, which was done previously. Okay. Can review all that. Okay. Live classes which were reviewed. And then you can also go on to do some very important topics. So we've broken all these things down for you so that before you come to the ethics class, you need to review all these. So some of these topics, this is just about 2 minutes. If you can see, it's just 2 minutes. Review it, then you go on to the next one. The Canadian healthcare system is just 5 minutes. Review it, and then you can come to what we call shared decision making. It's just 1 minute, 49 seconds. So you need to review all these topics one by one. What is do not resuscitate? Under what circumstance? What about advanced care directives? What about withdrawal of care? When are you going to call the coroner? Okay. What about medical assistance in dying MAID? What does it say? In 3 minutes, anything you need on MAID covered for you. Then you go on. What about accepting gifts from patients? What is the ethical consideration? What about if you are treating another doctor? What's the ethical consideration? What about if you have a medical colleague who is struggling? You are working in a clinic or a hospital and you have another colleague who is struggling. What do you do? Reporting another colleague. So you have all these topics. Some of them are just 56 seconds, right? Because, at MedCognito, we believe in something. You are going for an exam. You are going for an exam. You are not now coming to learn everything medicine, right? And then I want you to see something. We even have, we developed what we call med bullets. It's in the it's in the family medicine portal. I'm looking for it for you. And it's brought so much joy to a lot of our candidates. So the med bullet is like, concepts that we've summarized, right? And we've done it in a very random fashion. And each med bullet, so you take this med bullet 9, it contains 10 topics which have been reviewed. But you're reviewing those 10 topics in 8 minutes, maximum 10 minutes, okay? And we've loaded up to med bullet 170. So that means that 170 times 10, that means you have 1,700 high yield topics that you can review right now on your laptop, and all you need to do is, so every 10 topics, 10 minutes, boom, done. And then you go on to the next one, In fact, we are still working on more. And by the end of this week, we'll be at MedBullet 200. That will mean 2,000 high yield topics as well. So that is different from what is in your cardiology, ethics, geriatrics, that is different from all that. This one, we've randomized the topics. And so some doctors even play it in their car. It's like a podcast. They are listening. Like they listen over and over and over and over again. And really, it's been awesome. It's been superfluous. It's been awesome, right? And then, did you also know that you can even try? You can even try, you can try some mocks as well. So if you come here, I'm just looking for something for you. If you come here, yes. If you come here, okay, boom. You can do this one. You do the mock at your own time. So a mock on gastroenterology, it goes on and on and on, like different mocks. Some of them are 210 questions. Some of them are 10 questions. Some of them are 20 questions. A mock on neonatal resuscitation, oncal herniation, ventricular tachycardia, atrial fibrillation, infectious mononucleosis, like mocks on all of these important things. And this one is in your portal. So this one, you don't need to come to class to do it. This one, you do it on your own at home, right? Mock on black health, anorexia nervosa, choosing wisely Canada. Choosing wisely Canada is a whole new thing that a lot of candidates struggle with. And we've made it very simple. Mock on postpartum care, cardiology, and gynecology. So that some of the mocks, we also mix them up. So doctors, this is what MedCognito is here to get you. So don't forget, on November 18th, there's a live mock coming up. And I've shared the link with you. And then, you can get all these for even 1 month alone. And you can use that to prepare and you ask, okay, do I want to do it? But the truth is that many people who come in for the 1 month eventually will go like Dr. Brony, man, this thing is too good to be true. I want to get the rest. Okay. So for just 367, You can get everything in MedCognito. I mean everything. And I'm putting that link as well in the comment section right now. Everything in MedCognito, you can get it for just $367. By the way, you want to get it right away because our prices will be changing very soon. That one I'm telling you for fair fact, right? So for $367, you can get access to the live classes, which we will do during the period, the 1 month. You will get access to every material in MedCognito for just $367. So I've put the link in the comment section for you. However, you go like, man, my exam is in April. My exam is in May next year, or I'm targeting June next year. And Dr. Bruni, I want the 6-month program. I want the 6-month program. Okay. We also got you covered. So the 6-month program, that one also gives you everything, and you get to revise the entire content with us live twice. The entire content in MedCognito, the live classes and everything twice. All right. So that is only goes for $1,997 for 6 months. For 6 months. So doctors, I've put the link as well in the comment section. And someone may say, Dr. Bruni, I want to talk to you right away. I want to talk to you right away on the phone. I want to talk to you right away. That's my phone number, doctors. +1 306 891 5649. +1 306 891 5649. Call me right now. Right now. As we talk, call me right now, and I'll be here to help you. So, doctors, thank you very much for spending your Thanksgiving weekend with me. It's been wonderful spending this 1 hour with you. Please reach out. Bother me, okay? Bother me. Let's see how best we can help you in your MCCQE1 exam preparation. And let's take the game to the next level, okay? Our theme and our hope is that, we can help as many IMGs as possible to cross from failure to success so that we can all get into the system and help the Canadian healthcare system. Thank you very much, doctors. Reach out right now. I prefer WhatsApp. Okay? I prefer WhatsApp so that those who are not in Canada can also get in touch. So please, just get in touch right away. +1 306 891 5649. I'm waiting for the first call right now. Now pick it and talk to the candidate. If you are in Canada, you can give me a direct call, but if you also call me by WhatsApp, that's fine. If you're outside Canada, reach out. Let's help you in the MCCQE1 exam. Thank you very much. Enjoy the Remembrance Day weekend and stay safe. Bye-bye.